and end-of-life care and palliative care medicine. My name is Inge Eidemark. I'm a nephrologist, and I'm a consultant at the palliative care unit at Rigshospitalet here in Copenhagen. And my co-chair is Elisabeth Krarup. She's also a nephrologist, and she's a consultant at Herlev Hospital, also here in Copenhagen. Before we start the program, I want to mention this woman, Dame Cecil Saunders. She was the founder of the hospice care movement and the idea of palliation. In London, they can celebrate her 100th birthday this year. The palliative care, can I have the next slide? The Palliative Care Research Centre in London at the King's College Hospital carries her name. So with this in mind, I want to welcome the first speaker, which is Dr. Anya Burns from London. Anya is a nephrologist, and she has a long list of publications addressing the questions we are going to talk about today, namely conservative care management, the elderly with kidney failure, chronic kidney failure, and end of care problems. So, Anya, please.
Thank you very much. Good morning, everyone. It's lovely to be in Copenhagen. I have to say this is my first time visiting, and the weather's beautiful, so I better be interesting and exciting to be better than the weather outside. I was asked to give a talk on palliative care and end-stage renal disease, and asked to give an overview talk to set the scene. But to be honest, I think I prefer the title here, which is Delivering Holistic Care to an Aging CKD Population. In nephrology, and particularly in my hospital in northwest London, we've undertaken a remarkable journey in the last 60 years. This is a photograph that appeared in the Evening Standard newspaper in London in 1964. And it shows Stanley Shalden, who led the first chronic dialysis unit in the UK at the time. And these were considered the lucky 13 patients who were chosen to undergo dialysis, chronic dialysis treatment. So, fast forward 50 years, and here is our oldest patient on our dialysis program. Here he is in 2015 celebrating his 102nd birthday and still going strong at that time. He died actually only earlier this year, a couple of months ago, at the huge age of 105. And this gentleman here was the oldest man to run the London Marathon this year at 87. He completed the marathon in 8 hours and 11 minutes, which was more than twice the time that my two of my children, I should say, ran the same London Marathon. So these are what I call nature's aristocrats, amazing people who seem to survive and survive. But for the majority of our elderly kidney patients, I'm afraid, who undergo dialysis treatment, the outlook is not so good. This graph is familiar to us in the UK. It's from our UK renal registry, and it shows survival on dialysis according to age group. And you will see that the over 75-year-olds here fare very badly indeed, with almost 50% of them or so dead by 2 years from starting their dialysis treatment. And similarly, in America, the figures suggest that your survival is a third to a quarter of age-matched, non-dialyzed people if you're on dialysis therapy. And there is evidence that we actually harm elderly patients who undergo dialysis treatments. So this is a now pretty famous study from America, published in the New England Journal, of over 3,500 nursing home patients, and only 13% of those patients maintained their functional status at 12 months, and their mortality was equally high. And similarly, Jassel's group from Canada demonstrated that independent living was likely to deteriorate, or the numbers reduce, such that after 2 years, only 11% of patients undergoing dialysis, elderly patients, were living independently. So around 2003 or 2004, we began to think, do we need a new paradigm for looking after patients, elderly patients with advanced chronic kidney disease and end-stage renal disease? So we set up in our hospital and in many units in the UK, others were doing similar things, and we called our program our Maximum Conservative Management for elderly patients with renal failure stage 5. I'd like to just point out that this was a patient and family choice. There were no death committees. It was not rationing. It was not dialysis withholding in CKD. And some people have suggested that those elements were at play, but I can say that they were not. Our mission was clear at the time: to reverse any reversible factors, to preserve residual renal function, to anticipate and treat intercurrent illnesses, which I think is very important, to identify and treat, if we could, symptoms, to maximize the patient's functional status, to plan their end-of-life care, support their family and close persons, and minimize futile interventions. Since then, many units in the UK and around the world have set up similar programs, and we've ended up with a plethora of terminology and titles for this sort of treatment. So it's not only the titles that are different, though. What people mean by conservative care is very different. And in the UK, Paul Roderick and his group did a survey of renal units and found vastly different percentages of elderly patients established in conservative programs, and he discovered that what people mean in one unit by conservative program is very different from what they mean in another unit. And the reason for this, I think, is because this is not an easy topic. This is a very difficult topic. We're dealing with people who are frail, often have cognitive dysfunction. They may be depressed, lonely, bereaved. They have mobility issues, comorbidity. We have to have difficult conversations. Family wishes and absent relatives all play into the mix. So there are many, many factors that make this a very difficult topic. Coming back to my own unit for a moment, I'd just like to say that most of the patients who've chosen conservative care are elderly or very elderly. So these are just pie charts with the different age groups for the transplant patients, hemodialysis, PD patients, low clearance, which we use once a diabetic gets to an eGFR of 30 and below, they join our low clearance clinic. Non-diabetics, 20 mils a minute and below. And so our conservative group of patients are actually elderly or very elderly. And I've often asked this question. We have the most diverse population group in northwest London, with many different people and patients and staff from many different cultures and backgrounds. And it's interesting that actually the religious beliefs of those who've chosen conservative care versus those who've chosen dialytic therapies are pretty similar. Actually, there's no significant difference. So now I'm going to spend a few minutes talking about these few topics here: symptom burden and distress, performance status, survival and hospital-free days, quality of life and death, a little bit about decision-making, because we could be here all day if we stopped on that one, and then about a trial that we've just begun in the UK. Patients in being managed conservatively have many symptoms, and in fact, they're very similar in number and type to those on dialysis. Energy, poor mobility come up tops in most of the studies, but itching is down there someplace. And what's important too, I think, is that many of these patients have lots of symptoms. And these were 94 patients studied in Newcastle, mean age 85.9, GFR 17.8, and hemoglobin well maintained, which I think is an important fact too. We did a little study one summer when we looked at using a memorial symptom assessment scoring at about 14 patients, and we tried to do an assessment score as often as we could over a 2-month period. And you'll see here that the patient's symptoms varied from day to day. And that's indeed what patients say to us: I have a good day, I have a bad day. And I think in our therapeutic options for these patients, we've got to consider this factor. My PhD student, Dr. Helen Alston, used this distress thermometer to look at the patients. This is free and downloadable. And the way we use this is we give it to patients while they're waiting to come into the clinic to see a nurse or a doctor. And the patient's asked to score their distress on a thermometer here. And there are some prompts in relation to physical things, emotional things, social things, and spiritual things. So Helen has validated this tool. She's done a cross-sectional study, a longitudinal study, and some in-depth interviews of the patients to understand what the patients mean by distress. This is a group of CKD 4 and 5, 350 or so patients, and a similar number of dialysis patients. And you'll see a lot of the CKD 4 and 5 patients score 0, so they don't feel distressed at all, whereas the dialysis population have higher distress scores. We've just begun to look at the trajectories of the distress thermometer score with time. These represent individual patients, and the red line is they've gone on to dialysis treatments. And some get very distressed coming up to dialysis start, and then their distress abates, and for some they have very high levels of distress and remain distressed. These are small numbers yet, but we're beginning to come to analyse the data and also look at it in relation to performance status. Now, performance status excuse me, is very important. Fliss-Murtagh described a new trajectory of performance in patients with chronic kidney disease who are managed conservatively. Sorry. So for those who are not familiar with performance status, here's a patient who develops cancer and goes downhill quite quickly. Here's a patient who has COPD and has infective exacerbations and goes down in a stage-like fashion. And here's a frail, elderly patient with dementia who has a poor performance status, which gets worse until their death. So patients managed conservatively, Fliss did this study prospectively, maintain their performance status quite nicely until a week or so before they die. And then their performance goes down quite rapidly. So what about survival? Many people have tried to compare survival of patients who are dialyzed with those who undergo conservative treatment. The problem is, where do you begin the clock, or at what point do you begin the clock in the conservatively managed patients? Down here, this is Rachel Carson, and I used logistic regression to discover at what point we started dialysis in the dialyzed patients and use that point to start the clock in the non-dialyzed patients. And Hussein and their group, they're doing it prospectively, starting with an EGFR of 20 and then 15 and then 12. You'll see, by and large, it appears that those who are dialyzed outlive those who are managed conservatively. But when you drill down on the data, the survival advantage here in the dialyzed group goes away when you examine those with high comorbidity. So these are patients with low comorbidity, and these are patients with high comorbidity, and you see the difference begins to disappear. And similarly, if you look at patients aged less than 80, there appears to be a survival advantage of dialysis, but over the age of 80, that advantage disappears. And this is a relatively recent paper, and in this single centre observational study, there was no statistically significant survival advantage amongst patients over the age of 80 years old choosing renal replacement therapy over conservative management, and comorbidity was associated with a lower survival advantage. So the messages seem to be the same. When I started this work, I was very interested in out-of-hospital days, because I think survival is one thing, but if you're surviving at the expense of hospital days, that would seem to me to be not a good outcome. And here's a group of patients that we looked at, and these are the days spent in hospital or on dialysis. And for almost every day gained, it was at the expense of a day in a hospital or in a dialysis unit. And I think that's important. So what about quality of life and quality of death? Maria Gain from Lister and Stevenage has done a prospective 3-monthly quality of life HADS and satisfaction with life scale in patients for up to 3 years. In her study, the conservative kidney management patients were older, more dependent, had higher comorbidity and higher anxiety levels. But their mental health, depression and life satisfaction scores were similar in both groups. And those choosing conservative kidney management maintained quality of life, whereas those who went on to dialysis treatments, their life satisfaction component of their quality of life decreased significantly. And Helen Noble has done similar work in her PAC study. So, what about death? Our conservatively managed patients are 4 times more likely to die at home or in a hospice or place of their choice. Their final illness is short. Their EGFR, if they die of renal failure, and many die of other things, is usually around 4 to 6 pills a minute. And pulmonary edema, which was a big anxiety when we first started to send these patients to hospices, is really rarely an issue. Decision-making is a nightmare. We like to think we follow shared decision-making practices. There are questions around why do patients choose conservative care. Elderly patients, in my experience, have difficulty when we revisit the decision time and again. A number of units have developed decision aids and algorithms, and are they helpful? How many patients change their mind? How and when should we have these conversations? And there's a huge time factor, which I'm sure many people in the room are very familiar with. One study from China looked at why people choose conservative care over dialysis, and they about a quarter of their patients felt that they were too old. Patients were not accepting of dialysis therapy. Many had multiple comorbidities and poor functional status and cited that as their reason. A number thought that they'd be a burden on their family, and poor social support were all cited. In terms of shared decision-making, I think it's worth just thinking about that for a moment. While I say we aspire to doing this well, but many things conspire against us so that we do it badly, in my opinion, and that probably maybe you do it better here. But I think, again, dementia, mental capacity, depression, attention span, and higher mental function are all relevant here. I was taken aback recently when I was seeing a patient in my low clearance clinic, and we were having discussions about treatment. And I was a little bit alarmed that he wasn't quite taking in the information, and he had worked as a solicitor up until a week prior to my clinic visit, or so he told me. So I asked him to draw a clock and put in 11:15. And after about 10 minutes of prevaricating, this is the clock he drew. So I think it became clear to me that decision-making in this circumstance was going to be very difficult. So in summary then, I think we entered a new phase in a remarkable journey as nephrologists. Conservative care is a legitimate and positive treatment option. In our unit, it's chosen by about 10% of our elderly patients. It delivers maintained functional status and quality of life for many months, a short final illness, 4 times greater chance of dying at home or in a hospice setting, and survival and intervention-free out-of-hospital days may not differ much from patients who choose dialysis therapies, especially if you're talking about an over 80-year-old with high comorbidity. But yet, there are lots of unanswered questions and biases in this existing evidence. And so Fergus Kasky, who's here, has led a group of people who've designed a randomized controlled trial, which the National Institute of Health in the UK has funded. And we are now recruiting, and that trial will randomize eligible patients to preparing for dialysis therapies versus preparing for conservative care. Fergus is in the audience, so he'll be able to help us with questions afterwards. But we've begun recruiting, and we have a number of sites recruiting. So finally, I've just got 2 points I want to make. I think when we're caring for these elderly patients, we need to become more geriatrician in our practice. I think we are, at least in the UK, and we are poor at recognizing frailty in our patients, and frailty is a big issue that I think hampers our patients' functional status and quality of life. And also, I think if we work with our geriatricians, we might be able to minimize deterioration in functional status, reduce, for example, their falls rate. Geriatricians use a comprehensive geriatric assessment very usefully. We need to think about optimizing nutrition and minimizing muscle loss, and we need to think about advanced care planning. I took this photograph when I was leaving my office on Friday because it's part of an initiative in our hospital to get patients walking about rather than sitting on chairs and lying in beds, and trying to keep them active while they're in hospital. And I think these are important initiatives. And my very final slide is about how gratifying it has to have been involved in this whole journey. And these are a selection of the cards and letters from patients' families after some of these patients have died. They've been very grateful for the holistic approach to their loved ones' care. So thank you very much for your attention.
Thank you very much for an excellent talk. Unfortunately, we have gone a bit over time, so there will not be any time for questions at this point. Perhaps later on, I don't know. We'll have to see.